Hi, Dr. Tang, is that you?
Hello.
Hi.
Hi, how are you? Sorry, I finally got on.
Oh, thank you so much. No, we're going to wait for another, 5 minutes to see who else. Usually people are a little late, but
Okay.
this is Dr. David Tang-Wai, and
Hi.
this is our group. Usually there's more, but we'll see who comes up. Dr. Tang-Wai is a neurologist and co-director of University Health Network Memory Centers Clinic at
Yep.
University of Toronto. And as you'll hear, he spends a lot of time with posterior cortical atrophy, and thankfully he's taken it on as a research and clinical challenge to figure it out for patients and caregivers, and spends a lot of time really thinking about what is it in our lives that we can do to make our lives functionally better, not
Mhm.
just the disease progression, but what can we do today to navigate our worlds, both for patients and the caregivers who love you and want to help you make your world better. So I think that's really kind of cool.
Well, I'd like to thank you for inviting me. So this is a privilege. So thanks very much for allowing me to do this.
Awesome. So what we'll do is, I think, what time is it? It's 11:35. So I think that we're just going to start, and,
Okay.
and anybody who comes in will come in, and I'm going to just mute everybody. And I'm going to actually, I want to tape this. Oh, it's actually being taped right now. So, okay.
All right. So I'm just going to get my presentation started. And here we are. And all right. So
Posterior.
yeah. So today I just wanted to talk about posterior cortical atrophy and take it from the viewpoint of what people go through, not from the medical aspect, but what does the person who is afflicted by this unfortunate condition deal with, and how they express themselves and how they view the world. Because if I can understand that, can that help individuals in the future? How do I tinker with it? How do I overcome their disability? There's a different way of approaching it other than using medications all the time. So I really don't have any disclosures to make. The only acknowledgement, I mean, a lot of my work and a lot of my dealings, I can't do it without the people that I look after and the families, and allowing me to ask, interfere to some degree, to understand, to hunt, to peck. Without them, I wouldn't be in this current situation. And so these are the topics that I would like to talk about. I mean, what is PCA? I mean, what is the story that people often say? What are the key words or phrases that people would use that really any one of us should be able to recognize and actually consider it? And also for a physician to kind of consider it. What do we see typically in the office? I know Gil, I think, went over the revised criteria, but how do you link what people say to the revised criteria? What are the common causes, some of the treatment options, and any questions that you'll have as well. So throughout my talk, I actually do have quotations from all the patients that I've looked after. And this is one of them where this was the complaint, is that I could see but could not see. So what is posterior cortical atrophy? Well, I probably don't have to explain it to this audience, but posterior just means it's the back part of the brain that's being affected. Cortical is the thinking part. When we look at the brain, there really are two parts of it. One is the cortex, which is this outer ribbon that's involved with all the thinking, the processing, and everything underneath is just wires, what we call white matter. And atrophy is a shrinkage. And the way I teach shrinkage or atrophy to my residents and my medical students, it's like going from a grape to a raisin. There is that progressive shrinkage that occurs. so when we look at the back parts of the brain, we have to ask, well, what does the back parts of the brain do? What does it function on the day-to-day? So first, what lobes, which parts of the brain are involved in this condition? So one is the parietal lobe, and that's this green structure here. Then we have the occipital, which is really in the back part of the brain, and the posterior temporal, which is this other green area here. And what do they all do? Well, collectively, they're involved in some degree of processing of visual information. There's also an area for language. That also includes reading and writing. There's an area in that same part to, so how do you do things with your hands? How do you manipulate objects? How do you use a remote control or a telephone or a computer, for instance? There's an area of dressing, and there's an area of how to do math.
I saw your note, and I think there's time. I just want to double check with him before I schedule it. So it'll probably be tomorrow, like 2 or 3 o'clock, somewhere there. Okay. Okay. I'll send it over today.
Sorry about that. Go ahead.
That's okay. And you know, I first became involved with it when I was a very young resident, and you know, you would read the criteria, you'd read the original description in textbooks, but how do you recognize it? It's one thing to say they have visual spatial problems. It's one thing to say that they are progressing, but what are the buzz terms? What is it that am I supposed to pay attention to? What you're supposed to pay attention to know that, you know, this person here has posterior cortical atrophy. So what I like to do is to present a typical case, and it's a conglomeration of pretty much every case that I've seen throughout my career. And so this is a fictitious person. It's Nancy B, and she's 57 years old. And for most people with posterior cortical atrophy, which is uncanny, the majority are women, and we really don't know why that is the case, but that seems to, I mean, I saw it in my series. I think Seb Kretsch saw it in his series from UCL. It's also seen in the St. Louis group. But there's something about PCA and being a woman. There's a bigger association than with men. And again, we could not figure out why. And she comes in with, there's just something wrong with my seeing. There's something wrong with my eyes. And really, most people, there's nothing in their history to suggest a trigger, which typically there's nothing there. So there's no exposure to anything that we know of that would precipitate this kind of condition. So it's not medication related, family history. Yeah, there are people that could have a family history of dementia or Alzheimer's, but no one in the same family, to my knowledge, looking back over 100 years of literature, and even in my own patients that I see in Toronto, nobody in the same family has exactly the same disease. So this is her story. So 5 years ago, she was starting to complain of her vision, and it's a very non-specific. And say, well, it looks kind of blurry. And consequently, you know, what do we all do? We go see an eye doctor. And you don't see it once, you know, your vision is fine. Well, maybe we can tweak your glasses. And you get a new prescription, you put it on. It doesn't really help out. You go back to the eye doctor again, and the same pattern repeats itself. And eventually say, well, you know, it's probably not your vision, it's okay. And I thought this was a timely quote from a patient of mine recently. Every time I go to my eye doctor, he says my eyes are fine, but I still think there's a problem, and there is a problem going on. 5 years ago, Nancy B was complaining or noticing that it was difficult to read, and words appeared to jump out of the page, often losing her place on the page, couldn't follow a straight line of text, and then therefore when she read something, the sentences didn't make any sense. So what I have here is a picture. It's from one article, and normally when we scan a page, just follow the pink stuff, we go along, we change lines, we go along again, we change lines, we go along again. And some with posterior cortical atrophy, because there's a problem with their eyes and trying to follow things along the page, you may start here, you go across here, you go down, you may jump up, and it's very difficult to follow. What is someone is trying to tell you from a printed page if your eyes are darting all over the place? This is another example. This was work done at UCL, so University College in London. It's by Kier Young, who I know. And they looked at the reading differences between people with typical Alzheimer's disease, and typical Alzheimer's disease are people who just have the memory problem, the short-term memory problems at the beginning, and there's absolutely nothing wrong with their vision. And they compared it to someone with posterior cortical atrophy. And like any one of us, when we read, it reads as the most outspoken judge on the US Supreme Court has defended the use of some physical interrogation techniques. The judge told the BBC that smacking someone in the face could be justified if there was an imminent threat. Next paragraph, you can't come in smugly with great, and it continues on. That's normal. You track it accordingly. Someone with PCA is the most outspoken judge skips this. The US, maybe Supreme Court defended the use of, can't follow, jumps down to the next line, goes back up again. And you can see that just because your eyes are darting all around, you can't follow a line of text. Whatever anyone reads doesn't make any sense. So a year after the onset of her presentation, she was having difficulties filling out forms. And she would look at a form and it's full of boxes and letters and where to put this, and she just didn't know where to put her address or didn't know where to put her name or her signature. And then when looking at an analog watch, and it's very typical of looking at an analog watch that could not tell the time. And when you listen to someone, well, what is it about the time? Well, all the lines look like they overlap with one another. So where is the second hand? What is the hour hand? What is the minute hand? So it's all confusing, therefore you cannot tell time. Which also said, one easy fix to tell time, use a digital watch or a talking watch. So every time she opens up a drawer or looks in a refrigerator, can't find what needs to look for, even though the item is staring them in the face. And I've had some people who describe, and there is something on this is a video, there is something that has disappeared. And I've had people say, well, it's there, and in the blink of an eye, it just disappears. So in this case, I've got I think it's tape, and it comes in and out. And if someone is trying to find, we all have a junk drawer. And if you're trying to find, say, the hairbrush, you can easily, quickly identify, there's a hairbrush, right? Our eyes can target it very easily. Someone with this condition, they're looking all over, where is it? It may disappear, they're trying to scan, and they may completely miss it altogether. And that's difficult. I mean, they can't eat that way. They can't see their food that way. They can't find out what's in a drawer. They can't find out what's in a refrigerator. You can extend that into, well, they can't find light switches, doorknobs as well. And I had one person who described it like this. Well, you know, I look at things and it's trying to find Waldo. It was a beautiful description of what they went through. And for those who are really trying to look for it, for him, he's up in the corner over there. And then, 2 years later, she started to have difficulties bumping into door frames. And part of it may not be able to see off to one side. Part of it is, I actually don't see it, or I don't recognize that half my body is not quite aligned very well in a door frame. Difficulties dressing. And would look at the clothes, okay, what's front, what's back, and would turn it over, would turn it inside out, and would have a difficult time to orient the clothing relative to the person. The reaching out for things, this is where this optic ataxia is. You would reach out for something, your eyes would tell you, I think it's here in front of you, but you miss because it's someplace else. or you knock things over off the time. Because there is a spatial difficulties, and the spatial difficulty is where our body is in three-dimensional space, sleeping becomes a bit of a problem, because am I sleeping perpendicular to the long axis of the bed, or am I off at a funny angle and my brain is telling me something totally different? Can't do simple math, mixing up left and right, and that misreaching again that I had just described before. And then despite all of this starting up, then she's starting to notice some memory deficits. And this is, you know, you tell someone, or oh, don't forget we have an appointment. And then 2 minutes later, what appointment? What was that appointment again? Tell it again. Oh yeah, right. We got that appointment tomorrow. Forgets, ask the same questions. Husband started to notice that she was also having difficulties with trying to find the correct word to say in a sentence. And a lot of people, because they haven't been diagnosed, because this condition hasn't been recognized, they become depressed. I've had a lot of people become very anxious about it. Why? Because there is a feeling that, well, I'm trying my best to tell people what's going on, but you know, people don't believe me. We can't find anything wrong. What's going on here? So often I do see, unfortunately, a lot of people with the anxiety or depression. And once you tell them the diagnosis, things do settle down. What is this condition like? This is the husband of someone, of a patient of mine who passed away last year. And it was a beautiful statement. It said, well, it's like the projector works, but there is no screen. And your projector is your eyes. It's not an eye problem. This is completely a brain problem. So the whole point when someone gives a story of this is, how do you take all of those sentences, all of those statements that a person has, and what I do from a university perspective and from a continuing medical education is use what someone says, that's all that stuff in yellow, and what is that medical term? What does it actually represent? So that reading difficulties are jumping all around, we call it an optic tracking issue. The problems with filling out forms, looking in for all those items in a refrigerator, we actually call it simultaneous. And I know it's a long word, but it really means you cannot see more than one item at the same time. That your brain somehow is focused on the one item and it doesn't quite appreciate everything around it. The bumping in the door frame, is it because you don't see it or you don't perceive it? So that's the neglect or vision problem. Dressing difficulties, we call it dressing apraxia, and apraxia just means is the inability to do a certain task. In this case, it's the dressing that has the difficulty. Can't perform math, mixing up a right and left. There is a brain condition, we call it Gerstmann syndrome. I'll get into it a little bit later. But it's part of it. It is in the back part of the brain. Can't sit in a chair, sleeps perpendicular. We call it body space impairment, where the body is located relative to three-dimensional space. Misreaching, we call it optic ataxia. Ataxia is just a clumsiness. And in this case, the clumsiness isn't because of a muscle problem. It's not because of a coordination problem. It's because the eyes are deceiving you. It's deceiving you where the target really is. The rapid forgetting this is typical memory loss. And of course, it's at this time when most people get referred to a physician or to a neurologist. So I just wanted to go over these terms again, and I apologize if sounds confusing, but these are the two major brain symptoms that we do see in posterior cortical atrophy. One is called Bolin's, and these are what it's composed of. Simultaneous, again, with that inability to recognize this more than one object at a time. The optic ataxia is the clumsiness with reaching, and ocular motor or ocular apraxia, and which I have not discussed, but it means that the person cannot move the eyes to a particular target. So if you ask someone, well, can you please look to the left? They can't. But they spontaneously could look to the left. The other aspect is Gerstmann's. Acalculia is the inability to do simple math. I'm not talking calculus, I'm not talking about higher math. This is very simple math. Addition, subtraction, multiplication, division. Right and left difficulties, you're confusing the lefts and rights together. Dysgraphia means the inability to write. Cannot write at all. You make spelling mistakes. And finger agnosia is the inability to identify what the fingers are. So you can't tell what a thumb is, or your first finger, or your pinky, for example. What amazes me, how do they all put it all together 100 plus years ago, but so be it. And why is that important? Because those functions are all related to the back part of the brain. Now, we talked about Gerstmann's, we talked about Balint's visual field. So do you see everything in front of you, or is part of it blocked away? We talked about the dressing praxis, or dressing apraxis, the inability to dress. Spatial awareness, where you are in three-dimensional space. And neglect is a phenomenon where you don't recognize, you're not even aware of one side of your body compared to the other. And if you look at all of those functions, the pointer just keeps on going away, it's all in the back part of the brain. And we're going to use those functions to describe it's all related to the diagnostic criteria. Neurological exam, they can vary. Sometimes it could be normal. Sometimes it's not. And in this case, I'm putting an example here where it's not normal, where when I test the vision, really doesn't see off to one side, that she does have difficulties when I ask her to move her eyes in a direction, has difficulties to doing it, but again, looking at her, it actually looks normal. And you can see why some people may not believe an individual. You know, when I look at you, your eyes do move around well, but when I tell you to do something, to move your eyes to a particular direction, you can't do it. And unless there are very skilled physicians, some people may think, well, maybe you're just putting this on, which is not true. There is a real deficit going on. Does not recognize one side. And we'll get into later, some people can develop Parkinson's. In this case, there was no Parkinson's signs. There's no signs of weakness at all in the muscle groups at all. And is having difficulties knowing how to put on a coat. What's the front? What's the back? And you will look at someone and they are having that problem with the dressing. In these patients with posterior cortical atrophy, in these individuals, there is a big difference what that brain looks like. So I have here what a normal brain scan looks like, what a little bit of shrinkage, more, and this is severe. And it's the front of the head is up here. This is the back of the head. Traditionally, this is considered the right side, and traditionally, this is considered the left side. And the red line is the marker between the front part of the brain and the back part of the brain. And here's normal, what a normal brain should look like, that the folds of the brain look close to each other. And how I tell or review this with patients and their families is, your brain looks like this. This is normal. These are the folds of the brain. And as it shrinks, there's more space in between the folds of the brain. So if you look here, over years, there's just a little bit of shrinkage going on compared to the front. Now there's a lot more shrinkage compared to the front, and this is the severe stages. There's more space now than there were before. That's how we kind of look, that's what we look for on these scans. So that's a typical story. So how does all of those symptoms that an individual goes through relate to the diagnostic criteria? So this is what just came out middle of last year. We know that it starts slowly. There is no trigger. It doesn't start suddenly, gradually sneaks up on someone. We know that it gets worse. That's the gradual progression. We know that it has to be some visual symptoms with other aspects in the back part of the brain that we just went over. And these are the same symptoms that have been discussed. Simultaneous oculomotor apraxia and optic ataxia, that's the Berlin syndrome. So again, this is simultaneous, the inability to recognize more than one object simultaneously. Oculomotor apraxia is the inability to move the eyes to a particular direction. And optic ataxia is that clumsiness because of vision problems, not because of any other process. Constructional dyspraxia is the inability to just write. Environmental agnosias just basically are not aware of their surroundings. And we've talked about the dressing praxis or the dressing difficulties. Alexia is the inability to read. And everything in blue is the Gerstmann syndrome. Now, you know how all those functions relate to the diagnostic criteria. Limb apraxia is the inability, it's the, we talked about dressing, inability to dress. This is now the inability to do things with a tool. So you cannot use a remote control. You cannot use a computer or a fork or a knife. Aperceptive prosopagnosia, this is the inability to recognize faces, familiar faces. I know it's a face, maybe, but who does that belong to? Agraph is the inability to write. The visual field cut is you cannot see it off to one side. So you need 3 of one of these to be present. Early on, we know that memory is spared, and this is that short-term memory. We know that language should be spared at the beginning, so not affected. Executive function is the planning and judgment. So again, if it's very early in the course, so within the first few years, and someone has a lot of difficulty, it's, you know, posterior cortical atrophy is not a condition we would think about. And there shouldn't be any changes with personality or behavior. On the imaging, or whether it's a CT, MRI, PET scan, there is those changes in the back of the brain, which I showed you. And the other aspect is it can't be due to anything other problem. So you can't call a person with posterior cortical atrophy if, God forbid, they've got a stroke in the back of the brain, or they have a tumor in the back of the brain, because there's another reason to explain it. If they have a eye problem itself, glaucoma, damage to the eye because of trauma, again, you can't call this posterior cortical atrophy. When we look at the causes for posterior cortical atrophy, most of the time, and so far I'm pretty much getting about 90% looking at all the literature for the last 100+ years in our series, most of the time it's going to be due to Alzheimer's disease. And the other pathologies or other causes underneath the microscope is something called dementia with Lewy bodies. And dementia with Lewy bodies is related to Parkinson's disease. So people would have signs of Parkinson's. But they also have very bad dreams or nightmares. They have problems with blood pressure. They have problems with heart rate. In cortical basal degeneration is another condition. It's another cause, again, not very common. And in this condition, there is some Parkinson's symptoms, but it tends to be more on one side of the body than the other. There's a lot of language problems typically from what I've seen when I've looked at these individuals. But they also can have vision problems as well. It's rare to actually see it starting with a vision problem. I do have a few, but it's not very common. And then lastly, prion, and that's been reported before. And prion is that mad cow disease. This is extremely rare. It's very rare that this occurs. So I've said that posterior cortical atrophy most of the time underneath the microscope can be due to Alzheimer's disease. So how is it different from Alzheimer's disease? Well, so I created this table. I have typical Alzheimer's disease and posterior cortical atrophy, and what makes the two different. In typical Alzheimer's disease, it's that short-term memory problem. It is being told, oh, here's your appointment date, and literally within minutes or seconds, you forget and you ask again. In posterior cortical atrophy, which we've gone through for the last half hour or so, it's that vision symptoms that gets the problems. Which parts of the brain become first affected? Well, in Alzheimer's, it's that temporal lobe, specifically the memory structures. And then posterior cortical atrophy is actually several lobes being involved. So visually, it looks different. What about over time? Well, we know that in posterior cortical atrophy, it starts in the back of the head. Then it literally, the pathology does spread out from that one area. And as it spreads, that's how you get the rest of the symptoms. It depends on what part of the brain is affected. And in the Alzheimer's pathology affects that part of the brain, then you'll have that problem. And then it will spread even further. So it would be great if all these diseases just stayed in their one little part of the brain. Unfortunately, it doesn't do that. And it tends to go from one part and just moves ahead. And as someone with posterior cortical atrophy advances through the years, well, language eventually becomes affected, memory will become affected, and unfortunately, decision-making will become affected in the future. So using that same idea, well, how do you compare that to Alzheimer's disease? Well, this is posterior cortical atrophy. This is what I typically see. Well, they get all the other symptoms. Eventually, the decision-making becomes changed. And lastly, one of the last things I typically see is the memory problems. That's typically what I've seen in most of my patients. In looking on this side here with Alzheimer's disease, well, it starts with the memory. Then it tends to go to the back, but does not affect all of this at the beginning. You get a little bit of language difficulties, you get a little bit of writing, but I don't find it as bad as someone with posterior cortical atrophy. You get a little bit of decision making, and over time, over many years, the back part of the brain becomes involved, where you can get the difficulties with recognizing people. You can get difficulties recognizing more than one thing in that complicated junk drawer that we all have. So even how the symptoms evolve over time is very different from posterior cortical atrophy, even though it's the same plaques and tangles seen underneath the microscope. The genetics, somehow it kind of looks like Alzheimer's disease from a genetic perspective. That we know that ApoE4, which is a marker for late onset Alzheimer's disease, that if we compare people with posterior cortical atrophy and people with Alzheimer's disease, there's no difference in how frequent we see that particular allele. And the E4 is the one that confers the Alzheimer's disease or increases the risk of Alzheimer's disease. We did a very short study when I was a resident, when I was a fellow, I mean, can we find, we took the people who were the youngest ones. And if they're youngest, chances are we probably could find a genetic mutation. So we screened at that time, all the Alzheimer's genes. Can we find a mutation in these genes? And the answer was no, we did not find any. So from a treatment perspective, and the way to look at treatment, we have pharmacological, which is drugs, and non-pharmacological, which is the non-drug way. How do you manage at home? What can you do at home? Well, it's still the drugs we use for Alzheimer's disease. So it is still the donepezil, the rivastigmine, galantamine, memantine. I want to focus more on the non-drug way. I don't think there is a person who works with dementia who will not advocate for healthy living. We all do. It is the most important thing that anyone can, whether you're affected or not or healthy, you got to do it. It's actually great for life. But because of what people go through, because of what people have said to me, in Toronto, we've tried to figure out what can we do at home. So first thing we've suggested is increase contrast. And I've got a slide to show that. Get rid of the clutter. I mean, think of the junk drawer. And if you have a lot of stuff on the floor, a little stool, items on the floor, you probably are not going to see it. So get rid of it so that someone doesn't trip and fall. I've had people, unfortunately, bump into or walk into patio doors because they don't see the glass. For them, oh, it's an opening, I can see the back, I can see the trees, and they just bump into the glass. So can you identify the glass? Can you identify door frames? And we've suggested to families to make it easier to increase the contrast as well is paint a door frame an interesting color, bright orange. Somehow big, bright, contrasty colors works well. Here's the door frame. So every time you see this red frame, that's the door. Like most of us in our homes, our light switches are typically the same color as the wall. Well, they can't see either because it kind of blends into each other. Well, paint the light switch. So every pink rectangle that you see on the wall is a light switch because you can see the pink on top of a white background. Shadows is a major issue. The eye tends to trick. Is there something in the shadow, or is that an object, or is it truly a shadow? So increase lighting to remove the shadows. Again, this is another slide saying exactly the same thing, but isn't it just put something on the glass so you know there's a glass there? Decreasing glare. A lot of our surfaces are shiny, and I would like to emphasize the floors. I've had people who, because of the light shining onto a freshly waxed floor, they think there's water. And I've seen individuals literally walk around what is a bright spot on the floor. It's just the light reflection off in our hospital. No, I said, well, what's going on? Well, it's wet. So easy fix, don't use a high gloss wax. Matte is good because you're trying to help that person compensate for that. This is my take on contrast. It is much easier to see a red apple when it's actually red on a background. This is a common thing I hear. White mashed potatoes on a white plate. And where is it? It's easier to see this type of contrast. White mashed potatoes on a black plate. There are guards you can put on. We've had individuals who there's a metal guard you literally put on the side of the plate so that if someone is eating with a fork and may not be able to maneuver it very well because of that, again, an optic ataxia, at least they can scoop the food, hit the side, we call it a plate guard, hit it against the side, at least the food comes onto the utensil, and then they can eat properly. I probably don't have to explain to this audience, PCA is not an eye problem. It is not an eyeball, it's exclusively a brain problem. Then over time, other things develop. So we've talked about language, we talked about can't do things with the hands, we talked about judgment, and then again, short-term memory. This is a list of, I'm missing yours. I thought I organized this. I'm missing PCAvision.org. I'm sorry about that one. But this is a group of support groups I've been collecting for the last several years. This is very much the one slide that summarizes everything, but I think we've already discussed all of this. And I think that's it. Yeah, that's it. Any questions?
That was terrific. So that was just beautiful. Thank you so much. And what we're going to do is very simple. If somebody has a question, I know I do, just raise your hand and I'll unmute you. And since it's a small group of like 20 people, like 10 from each place, why don't we just take a moment and Steve, why don't you introduce yourself so that Dave knows who you are, and it's always good because there's so few people in research that if you want to, get involved, like, this is one of the scientists who's good to know. Dave, you want to introduce you and your wife?
Yes, my name is Steve, and with me is my wife, Debbie. Debbie was diagnosed with PCA in the spring of 2016, and as you were presenting, Doctor, she was shaking her head about most of the things you said in terms of early changes or problems that she was having, repeated visits to the ophthalmologist, and so I think she very much fit into your model. So, and then after other people introduce themselves, I do have a couple questions for you, but I want to thank you for taking the time. The presentation was very good.
Well, thank you for listening.
Awesome. Colleen, I know you're at work, but did you want to say something? Colleen? Oh, she has to chat. Let's see if she is. My father has been diagnosed. He lives several states away. Okay. But I'll try to be as supportive as I can. Awesome. Thank you so much, Colleen. And, Mr. Cosgrove, hello.
Hello. I'm here with Paul Cosgrove. I'm here with my wife, Kathy. She was diagnosed in 2015. Do you have any questions?
No, I just said the same thing that I've been going through, pretty much.
Wonderful. Thank you so much, Kathy and Paul. Pam, you're on.
Hi, Pam O'Donnell. I've been working with my best friend who has PCA since she's developed it in 1999. Did not get diagnosed until I figured it out in 2011. Finally diagnosed by a doctor in 2012. And we've been trying to do different things. In your letter that you sent a copy to Dee Bingham back in 2012. And that letter you sent her telling her how to make changes to her home were really invaluable to us. We made major changes and they've really helped us a lot. Thank you. Decluttering was one of the big ones. And thank you also. I noticed you had my Pinterest site on your list of websites. You only had one of them. I have more, but thank you.
Okay. Thanks.
Maybe you can share them with Dave, Dr. Tang-Wai.
Sure.
Okay, awesome. So I see an Apple iPhone. Do you want to introduce yourself?
It might be me. I'm Joanne. My husband has PCA. Started having symptoms in 2006. And has gone through all of the things that were discussed. I was just hoping that he would talk more about, as it progresses, the agitation and combativeness that can occur.
So, as with any dementia, whether it's posterior cortical atrophy, typical Alzheimer's disease, it doesn't matter the actual cause. From my experience, you do get the agitation, the aggression. And it's one of the most unfortunate aspects about dementia. A lot of the aggression or agitation, some of it is not knowing or not appreciating what's going on around them. I've seen some, it's actually a language problem. They don't understand what someone is trying to say. How does one deal with it? It's not an easy answer, as much as I think a lot of people would like it to be. From my experience, one usually needs to understand under what circumstances that occur. A lot of agitation or at least aggression could be related to just changing, having a bath. And then dig deeper, well, what is it about that activity that they dislike? Is it the fact that they think they have already had a bath? Is it, I've had individuals, well, they just don't like to be cold. And find ways of making the environment more easier, more, in that case, make it warmer. I think there is an impetus to use medications as much as possible to help with this. Don't like doing that unless it's absolutely necessary. I'm not saying that it's always easy to know what's going on, but trying to understand what's going on is actually a major step. Because then you pattern the event to a particular behavior, and we try to modify the behavior. In Toronto, at least, I think we're very fortunate, even though we're kind of cash-strapped country. We have something called behavioral support outreach teams, and I adore them. They're wonderful. These are trained psychologists. Some of them are nurses. Some of them are occupational therapists, and they're my eyes and ears sometimes. And they go out, they look and see, well, what's going on there. And they do a two-step approach. The first is observe, see what's happening in the family, see what's going on, what are the dynamics involved. And then we'll say, well, let's just try these very simple strategies. Does this help with the aggression or not? Does this help with the agitation or not? And if that fails, okay, now we start with medication. And then they'll contact me, okay, there's something going on. And I know some of them well, they know my emails, we chat. So it isn't just a physician directed, it tends to be more of a collaborative effort in this case. This may not be the answer you're looking for, but for me, it really depends on what's going on, what is setting off a particular behavior.
Wonderful. Chris, I'd like you to just say hi, introduce yourself.
Yeah, so I've been diagnosed for a little while, early onset, and one of the things that struck me as you were going through was not just the confirmation as far as a lot of the things I've experienced, but also the way it is in the current experience also, and things that I had not put together as even necessarily being related yet.
Okay. Thank you, Chris. We don't really see you, but I guess maybe you don't want to be seen. Or...
I'm actually on a bus, so it's not enough of a connection to be able to see.
Awesome. Okay. We have a couple more. Paula. Hi, Paula. How are you?
Hi, Jamie. Sorry to be late. I found Dr. Tang's graphics to be so instructive. I'm going to want to go back and look at those a little bit more closely, but I appreciate the work that he's done so far, and I look forward to the other lectures.
Wonderful. Thank you, Paula. Paula, do you want to say, are you a caretaker or?
I was diagnosed with PCA last June, 2017. I live in Austin, Texas.
Wonderful. Thank you so much. Anybody else on the phone? There's somebody on the phone. I just.
Hey, Jamie.
Hi.
Hi, this is Greg Edgen. My wife, Mary Ann, was diagnosed in July of 2017. We are in northern Michigan. She found, thank you, doctor, also for your presentation. While we were listening on the phone, however, as soon as I'm able, I'll pull it up online because it has a lot of great information, and really appreciate your efforts.
Wonderful. Thank you so much, Greg. And please come today to the support group. I'll mention that in a few minutes. There's a call from also a caller from 303 area code. Hello? Hello? Maybe they're doing something in the background. Anyway, let's open it up for the last few minutes to questions. Steve, you said that you had something you wanted to say.
Yes. Doctor, once a diagnosis is made and confirmed or supported by imaging, what's the best practice in terms of repeated imaging, and what value is there to doing repeated imaging over the course of the disease?
I think practices vary, and I don't think that imaging, personally, I'm two minds. So the research part of me would love to have an MRI done every single year. The practical, highly Canadian part of it is there is not much money to do that every single year. And I personally think it's more valuable to listen to someone and see what the changes have been over year to year and what function changes have occurred year to year. I mean, if any of the slides, it tells you we know what parts of the brain does what. And if, for example, I'll use this as an example, that yeah, at the beginning you have the problems with the looking into a refrigerator, and maybe a little bit of math difficulties. So we know what part of the brain is involved with that. In a year from now, let's just say the dressing part starts. Well, I know what part of the brain it is. I don't need the MRI to tell me what part of the brain has been affected. If, however, something suddenly changes, so for example, if someone had a stroke, yeah, in that case, by all means, you got to do a scan. But also, remember how I kind of put all those arrows that we kind of, this is what we think the trajectory is. It may not be perfect, but we kind of know it. What happens if it completely goes off kilter? Like something not in that vicinity changes all of a sudden. Well, that's just weird. That doesn't make sense. In that case, I think an MRI or another imaging is worthwhile because it just doesn't follow what we're expecting.
Thank you. So,
Okay, thank you. I did have one other question, if you don't mind, Jamie and Doctor. And now it just crossed. In terms of progression, you know, we all have heard, you know, everyone progresses at a different rate. And I don't know whether, Doctor, you can say anything more specific about progression and whether or not, you know, if you see a certain thing happen, then you know that that means the disease is progressing faster than it had been historically. And then I guess more generally, and this might be a difficult topic for people to listen to, but can you say anything about the presence of the disease and life expectancy?
When we looked at it among our patients that we had seen, I was a little biased when I first looked into it. I thought people lived longer. In general, people were younger to get the disease, and I thought they were healthier, and they would live longer than the typical 10 years that people say with Alzheimer's disease. So that was my original impression. And then when we looked at Mayo with all of our patients there, it turned out to be about 10 years. And I was shocked, actually. I wasn't expecting that because the people I saw were well past 10 years. But as a group, it's about that long. That says the duration. It doesn't say rate of change or how fast or how slow that goes. I think that is variable from person to person. I've seen now enough in pretty much most age groups to see whatever I had thought originally, well, that person has just doesn't fit with my model, and I got to rethink my model again. The range, I think, now is still roughly 10 years, and I will add a plus minus 3. That's been what I'm starting to notice in Toronto. And I think what I have seen now from the people I've looked after up here, if there is more things happening, for example, if there's some Parkinson's occurring, I feel that tends to accelerate the disease a little bit. If there is some medical issues going on, that tends to accelerate the disease. So one of the things I'm always frightful of is people swallowing. And if swallowing becomes a factor, and I'm saying it doesn't always occur, but I've had a few who have, it tends not to go very well, because if you're not swallowing very well and you get into the wrong tube, then you get into a pneumonia situation, and then there's a different problem that has cropped up. If you're healthy, if you have no medical issues, one passed away, I've been seeing him now for 12 years. And that's, there's a lot of determinants. The healthier you are, I think, the longer you'll live.
What is the cause of death then? I mean, if they still look healthy at 12 years?
It still tends to be an infection. I think there is a family perspective that, even from a patient perspective, they have, how do I put this? Decided when it's time not to go be aggressive. As hard as it is to hear that. So it does tend to be that.
Can I just ask you a question? And I don't want to hog the floor here, but I think a lot of people think about this. Do we know any explanation for why it's happening in the 50s and 60s and Alzheimer's is later?
The short answer is no. I think overall, when we look at, and let's just say Alzheimer's disease, I'll forget the other causes of PCA. In general, well, let me preface it this way. So in Alzheimer's disease, you can have about 3 to 4 major presentations, and it's still due to Alzheimer's disease underneath the microscope at pathology. The most common one tends to be the one with the people with the short-term memory problem, that rapid forgetting. You tell something and it quickly disappears. And then we call the atypical forms, the unusual forms, posterior cortical atrophy being one of them. But there's a language one where people forget words as a presentation called logopenic progressive aphasia. We have one that it affects the front part of the brain, we call frontal variant. And these individuals on the whole tend to be younger than the ones who develop the short-term memory problems. So I don't know, is it just PCA itself for the younger people, or is it, if it's not in the memory structures traditionally and it affects some other part of the brain first, what is it about this group? Are we at risk? Is someone who's younger at risk to develop in one of these areas? I don't think anyone's ever actually knows that answer or not. Yeah, that's my big roundabout way of saying I really don't know. But there is something about this group and why are they different than everyone else.
Right. Okay, are there any other questions? You want to just raise your hand real quickly and I'll go through and see if I can, well, Chris, you're of the iPhone, Colleen, if anybody has a question, you can unmute yourself and ask it. Otherwise, we will say thank you and bid farewell.
One thing, could you explain neglect again? I think we're experiencing that, and I'm not sure if that's the right term.
Okay, so neglect is, trying to find a good analogy.
Guess I could tell you what She'll be sitting in a chair and her dog will be in her lap and she doesn't realize it's there. She'll ask where the dog is and she'll even stand up and the dog will fall on the ground. You put something in her hand and she doesn't feel it, only feels with her fingertips. Would that be neglect?
No, I think the dog.
Okay.
So the dog one could be the vision aspect, that it's changed so that it doesn't even see the dog. That's one possibility.
Yeah, she doesn't see the dog no matter what. It's a feeling it.
Yeah, the feeling it may get there, but neglect is really not even knowing there's something. We don't say, it's usually not in front of you. We usually neglect is off to the left side or to the right side. And there's a complete unawareness on that side.
Yeah, okay, we're one side, you neglect things on one side, but not the others. We neglect just about everything now, but yeah.
Yeah, that's typically when we describe neglect, that's what it is.
Okay, that's what I was trying to figure out. One side, not the other. Okay, thank you.
If anyone in the audience does notice someone having neglect, I think it's very important to recognize that. Part of it isn't that it's present, but how do you approach someone with that problem? If let's just say someone doesn't recognize the right side. So anything that happens on the right side of the body, on the right side of their space, they don't know what's going on and they're, leave it there. So if I know that, well, I don't address anybody from the right side. I don't come to somebody on the right side. I actually will purposely move myself around to come in from the left side so they know I'm in there. I will talk to them on that side. I will say hello on that side. I will talk to them. I will shake hands with them on that side, or else they don't know what's going on. And I think that's an unfairness. So if you do see people like that, or someone if you know has that condition, go on the other side. And it's not that they're ignoring you; it's just they're neglecting.
Wonderful. Well, this has been a great talk. Thank you so much. If anybody wants to contact Dr. Tang-Wai, do you want to give them an email?
Sure, I can do that. You got a pen? So it's david.tang-wai, so it's my name, at uhn.ca.
And this will be posted in another hour. And don't forget, everybody, we're having our support group this afternoon. And if you want to write down, and I'm going to put this on Facebook, it's the number for the meeting is 957-388-878, and it's at 5 o'clock Eastern time. So it's in a couple hours. Go have lunch, go do something, come back, please. And thank you. Oh God, you were fabulous. And we hope you come again.
Right, my pleasure. Thank you for inviting me, Jamie.
Thank you, everybody.
Bye.
Bye.